Welcome to the image analysis for the calcaneus. We're going to review the common projections for the AP axial and lateral calcaneus. We're going to review image analysis guidelines, common positioning errors, how to identify them, and how to take corrective action. Image analysis guidelines for the axial projection of the calcaneus states that the talocalcaneal joint is demonstrated as open. The calcaneal tuberosity should be demonstrated with minimal distortion. The distal metatarsals are not demonstrated on the medial or lateral aspect of the foot. The sustentaculum tali is in profile. The proximal calcaneal tuberosity is at the center of the exposure field. The calcaneal tuberosity and talocalcaneal joint spaces are included within the exposure field. Here are those guidelines for your review. So now let's talk about proper positioning and central ray angulation to open that talocalcaneal joint space. In an axial calcaneus projection, the talocalcaneal joint appears open when the central ray is properly aligned parallel to it. With the plantar surface of the foot positioned vertically or at that 90 degrees, the talocalcaneal joint space forms a 40-degree angle with the IR. To maintain proper visualization, a 40-degree cephalic central ray angle is used, aligning it parallel to that joint space. This positioning also directs the central ray nearly perpendicular to the long axis of the calcaneal tuberosity. However, because the tuberosity is tilted relative to the IR, there will be some elongation present. Now let's discuss what occurs when the foot is seen in an excessive dorsiflexion. If the foot is dorsiflexed beyond that vertical position of that 90 degrees, while maintaining a 40 degrees central ray angulation, the talocalcaneal joint will appear closed. This occurs because the central ray moves closer to a perpendicular alignment with the calcaneal tuberosity, resulting in less foreshortening of the tuberosity, but enclosure of that joint space. So remember, we're trying to open that talocalcaneal joint, so we need to ensure that that foot is at that 90-degree or vertical position with the IR. Now conversely, when the foot is in plantar flexion, this describes patients who have probably sustained trauma to the calcaneal tuberosity. Often they'll struggle to achieve that full dorsiflexion to 90 degrees with the lower leg. In these cases, if the foot remains in that plantar flex position while using that 40-degree angle, the talocalcaneal joint space will be closed and the central ray will align more parallel to the tuberosity's long axis, which causes excessive foreshortening of that tuberosity. Again, in this case, we may have to adjust or critically think on how to better achieve this image. You have two options here. You could repeat this image utilizing positioning aids to get that foot more vertical, or you could position the patient for an axial projection dorsoplantar projection. So now let's discuss the importance of proper positioning of the leg and ankle to accurately attain an axial calcaneus projection. If the leg is internally rotated or the ankle is inverted, the first and second metatarsals will be visualized medially. Conversely, if the leg is externally rotated or the ankle is everted, the fourth and fifth metatarsals will appear laterally. Ensuring correct alignment of the leg and foot helps achieve an optimal projection, preventing distortion and maintaining accurate anatomic representation. It is your turn to analyze a axial calcaneal practice analysis. Go ahead and do so and answer the following question. So let's conduct this practice analysis together. When evaluating an axial calcaneal projection, you want to look for a couple things. First, you want to identify whether or not the talocalcaneal joint is open. If not, is there any distortion in the anatomy? Is there any elongation or foreshortening of that calcaneus? And then, is there any rotation, or do we see any metatarsals medially or laterally, which will again identify rotation? So in this axial calcaneus projection, we see that the fourth and fifth metatarsals are visible along the lateral aspect of the foot. This indicates that the ankle was externally rotated or the foot was everted during positioning. To correct this and achieve proper alignment, internally rotate that leg to position the ankle in a true AP projection, or adjust the foot to a neutral position, ensuring that there's no eversion. This will help maintain accurate anatomic representation and prevent rotation and distortion. Let's move on to the lateral projection of the calcaneus. Image analysis guidelines for the lateral calcaneus projection state that the lower leg and foot are at a 90-degree angle with a neutral ankle joint. The proximal talar domes are aligned. The tibio-talar joint space is open. The distal fibula is demonstrated about a ½ inch distal to the distal aspect of the medial tibia. In an average medial arch, you will see that 1/2 of the cuboid is visualized posteriorly to the navicular bone. The talar domes are aligned anteriorly and posteriorly. The anterior aspect of the distal fibula is aligned with the mid-tibia. The posterior half of the distal tibia superimposes the fibula. The mid-calcaneus is at the center of the exposure field. The tibio-talar joint, talus, calcaneus, and calcaneus articulating tarsal bones are all included within the exposure field. Here are those image analysis guidelines for your review. We know that proper positioning of the lower leg is essential for an accurate lateral calcaneus projection. There's a few items, just like in a lateral foot projection, that you really want to look for to determine accurate positioning. That is going to be the positioning of the talar domes. Are they superimposed? The positioning of the fibula in its relationship to the tibia. And also the positioning of the cuboid in relationship to the navicular bone. If the proximal lower leg is elevated, the lateral talar dome will appear superior to the medial talar dome. In a patient with an average medial arch, less than ½ inch of the cuboid will be positioned behind the navicular. The distal fibula may appear too high or too close to the distal medial tibia. The talocalcaneal and the tibiotalar joint spaces both will be demonstrated as closed. Now, on the other hand, if the distal lower leg is elevated, the lateral talar dome will shift lower than the medial talar dome. More than a ½ inch of the cuboid will be seen posterior to the navicular bone. The distal fibula will be positioned inferiorly to the distal medial tibia. All these positioning errors occur because of inaccurate lower leg positioning. So it is essential to ensure proper alignment of the lower leg in order to attain a well-aligned lateral calcaneus projection. This reduces distortion and improves overall diagnostic quality. Again, let's take a look at how we identify rotation. As we discussed in the lateral foot projection, the same anatomic alignments are essential for accurate lateral calcaneus positioning. So you want to take a look at the positioning of the talar domes, whether they're superimposed, whether or not we can identify the tibiotalar joint space being open. The talocalcaneal joint space should be open, and the positioning of the fibula to determine whether there is any rotation. If the leg is externally rotated beyond the appropriate positioning, where there is more pressure applied at the forefoot, the lateral talar dome will appear posterior to the medial talar dome. Additionally, the anterior fibula will be seen posterior to the mid-tibia on the image. Conversely, with internal leg rotation, where the more pressure is applied at the heel, the lateral talar dome will shift anterior to the medial talar dome. And in this case, the anterior distal fibula will also appear anterior to the mid-tibia. Maintaining proper positioning and alignment helps prevent this rotational distortion. So, and overall improving your image quality. Go ahead and review this first practice analysis and answer the following question. When conducting this analysis, you want to ask yourself, do I have open joint spaces? What is the positioning of my talar domes? Are they superimposed? Do I have what is the positioning of the fibula in relationship to the tibia as well? And you can also utilize the positioning of the cuboid and its relationship to the navicular bone. In this lateral calcaneus projection, we see that the medial talar dome appears posterior to the lateral talar dome. This is indicated by the anterior distal fibula aligning anterior to the mid-tibia. These findings suggest that the leg was internally rotated during positioning. To achieve proper alignment, we want to externally rotate that leg until the lateral foot surface is positioned parallel with the IR. This adjustment will ensure accurate anatomic representation and reduce that rotational distortion. This concludes our image analysis for the calcaneus. If you have any questions, please feel free to reach out.